I wanted to talk a little bit about infection prevention and control, or also IPC as an abbreviation in the 21st century. So what can we do to fight infections and leveraging the new methods that are there like artificial intelligence and big data usage? But first of all, sorry, it does not move on. There we go. I need to make a little introduction because what is the actual issue that we are fighting and facing in the hospital and in the public health sector, which are nosocomial infections. In Germany, we are counting about 400 to 600,000 nosocomial infections per year, which is quite a lot, to be honest. And they are associated with a significantly higher mortality rate. With a nosocomial infection, the mortality rate in our patients is about 13%, and without is only 2%. For those who are having an infection, but not from the hospital side. And also, which is aggravating the whole problem, is that 1/3 of all of these nosocomial infections are caused by multi-drug resistant organisms, which are in particular bacteria. And I want to show you something because often in the media you will see coronavirus and other viruses or Ebola virus that is actually going on at the moment. But they are always called slow and fast pandemics. And the bacteria, I think, are often a little bit neglected because if you look at the bacteria, this is an example for a resistant Klebsiella pneumonia bacteria, which we documented in 2003, the first major outbreak in France. However, if you look 20 years later, you will see in 23 that there are outbreaks everywhere in Europe. And we can see that, or you can see that worldwide, basically, meaning that this is also a pandemic like the coronavirus. However, it is much slower. And if we want to break the chain of infection, if we want to stop this pandemic, even if it's a quick one with viruses or a slow one with bacteria, we need to understand more about the patterns of transmissions. And this is what our research at my institute is also in part of focusing on. So let me just get quickly into this. What are the reasons that these multi-drug resistant organisms are increasing? Well, it's not black and white. They are, for one thing, the selection, which means the inappropriate and indiscriminate use of antibiotics, be it in the hospital or be it in the veterinary sector or in the industry of meat production or animal product production, for example. But there's also obviously the transmission factor. One we can control by infection control measures, which might be inadequate sometime, and others we are not really able to control yet. It's the intra and interspecies transfer of resistance factors, meaning that bacteria can interact with each other and exchange DNA, basically, plasmids, etc., and exchange transmission resistance factors and virulence factors. And there are other factors we are not entirely able to control, or basically also not able to control, which is the host factors. Why are we as humans getting infected? Well, there are, for one, demographic changes in wider areas of Europe and in Asia, meaning that we have a more elderly population that is more prone to get an infection and are less able to fight this infection off without therapy. And we have an increase in invasive and immunosuppressive therapies in modern medicine, which is very good because we want to have this invasive and immunosuppressive therapy options. However, they are making us more vulnerable for infectious diseases, meaning that we will, in the future, very likely not be able to see an actual decrease of infections because we have a more and more elderly demographic population. And also, to understand how infections are traveling worldwide, we need to understand how we are traveling worldwide, because viruses and bacteria are not able to fly. They are able maybe to fly for a certain area, like a meter or two, but they are not able, like a bird, to fly from place to place. Meaning that you can see sometimes in the media, for example, the bird flu, which is indeed transported by birds over larger areas, but the main factor of transporting bacteria or viruses or infectious agents are we ourselves, are the humans. And this is, for example, just the flight connections on the planet Earth of one day. And you can see, if you see that 245 million passengers a year depart from German airports alone, that is quite a lot of traveling. There's quite a big chance of people transporting bacteria, carrying bacteria or viruses with them. And for that, together with the mathematicians, we developed a theory of infection to understand how this transmission works, which basically means that the R naught, or the basic reproduction number, which you can see here, means that you have an index case, is the first one here, that is infected, that has an infection. And an R naught number of 2 means that he or she will infect 2 more, then again 2 more here, which is 4. And then you have the logarithmic scale of an infection that just grows bigger and bigger. However, this assumption, this mathematical theory, assumes that there is a perfect connectivity between all humans and everyone is connected to everyone else in the same pattern and way, which in reality is not true. Because in reality, a real network, a real social network of human interaction looks more like this. Let me explain shortly how you can read this graphic or map. This, every circle, every dot basically is a human being. And the bigger the dot, the more contacts he or she has with somebody else. The lines here, the thicker they get, the more frequent is a contact, and the direction of the line is who is connected to whom. So these two, for example, share frequent contact. They meet every day, basically, for example. They are good friends. And what you can see here is that you have a central network, which has very, very frequently contact with other people, that is very well connected basically to the whole network. But you also have outliers, like on the right and top here, these 5 persons, for example, they are in contact with each other, but they are not in contact or barely in contact with the rest of the network. Which means that if you have a virus or a bacteria that has a high R naught number, like measles, and you assume that this population is not vaccinated, for example, means that if you have an index case or first infected measles case in this central group, then this will spread like wildfire. The whole population will be infected with measles, basically. But if you have it here in this single person, or these persons that are only in contact with each other, only 5 persons, a group of old ladies playing pool once a week, for example, this group will likely infect itself, obviously, but the infection will probably not spread to the whole population and the network, which means that the R naught number, it is not meaningless. We attach it to all pathogens, but it is a rule of thumb. It gives us the general idea how fast an infectious agent is able to spread or not to spread. But to actually predict and to stop an infection spread in the population, we need to know the underlying network. Otherwise, it's meaningless, because the network is the main character, or the main, it creates the main force of how fast an infection can spread or not. And usually we don't know the network. That is the problem. So what we are doing is trying to combine this infection control research, these interventions with mathematicians, with prediction models, and also with sequencing. And I want to show you something. This was a very good work in the 2012 and 18 years. It was the beginning, basically, from Chibbe Donker, very nice researcher from the Netherlands, moved to England, then to Germany. And he did the first assessing the risk of connectivity, basically. What you can see here is basically the map of the United Kingdom. Every thing here, the blue, the black, the reds, and the blues are hospitals. The blues are hospitals connected as teaching hospitals. The red are the university hospitals, and the black ones are smaller hospitals, general practitioners, etc. What you can see is there is regional network constitution, because between university hospitals, between the red squares here, there's rarely an exchange of patients. So this network is based on patient exchange, who transfers a patient to whom. And what you can see here is basically that obviously, if you're having a heart attack or a problem with your heart, you go maybe not a heart attack, a problem with your heart, you go first to your general practitioner. He says, oh, you need to see a cardiologist, transfers you to a cardiologist. Then he says, oh, that needs to be treated in a hospital, transfers you to a smaller hospital. After a couple of years of therapy, these smaller hospitals say, oh, you need a heart transplant. We cannot do it here. You are transferred to the university hospital. That is the the way of a patient, usually that is getting worse in his or her condition. Which means that between university hospitals, there's usually no connection at all because they all do the maximum care. So, but between the local network, there's lots of connection because once you're treated in the hospital, you get retransferred to smaller hospitals or to rehabilitation centers, etc., etc. What they found with this, analyzing the multi-drug resistant organisms, they found that the more central, the more connected a hospital is, the higher the rates of multi-drug resistant organisms are, which is not really surprising because if you're having patients that have been in contact to several hospitals already, they might have received antibiotics, which is a risk factor, and they might have been in contact with nosocomial adapted strains, which is also a risk factor. It's just statistics. They have a more or a higher risk of being colonized with the multi-drug resistant organisms. However, still today, even it's now 10 years later, basically, we are still measuring in Germany the quality of a hospital based on MDRO rates, which is entirely not true because you need to see the network position, because a high MDRO rate in a central hospital is not comparable to a high MDRO rate in a not central hospital. But what they also found in these early works was that the genetic relatedness of multi-drug resistant organisms also increases with the degree of connectivity, meaning that we have an infection control, a hygiene problem. Because this means that a multi-drug resistant organism is traveling around, transmitted between patients in a hospital network, which means that we have highways basically of patients that are going always the same way from the university hospital always to the same rehabilitation center, and there is exchange between nurses, doctors, patients, and there are multi-drug resistant organisms adapted to the hospital setting that are transmitted. They should not be genetically more identical based on the network position, but they are, which means we have a job to do, homework to do. We need to stop this transmission. That should not be happening. And for that, we need to understand network boundaries. When are transmission happening and when are they not happening? There was an interesting work typing Staphylococcus aureus, which is a bacteria that is colonizing the nose-throat area in the German-Dutch border region. Red here, the Dutch region, black, the German region. And here you can see the two flags, Germany and the Netherlands. What they found in this group were that the genetic relatedness of the Staphylococcus aureus in the Dutch region, let's say there were predominant types, the green one and, well, mainly the green one, which is T108. And in the German sector, there were red and blue ones, the 08 and the 02. What you can see here is on the first, you look at it at the first time and you see, okay, they are not related, which is true. Mainly they are not related, meaning that there is not a lot of transmission between the two populations, although the borders, as you know, are open. People are traveling there, going to get to the supermarket, or because the gas is cheaper on one side of the border, so there's frequent traveling. And when you look at a respiratory transmitted virus like corona, this border was not visible because they were transmitted in the same way. There was not really a border that could be measured. However, in bacteria with the Staphylococcus aureus, there is a border you can actually make visible by typing them. And why is that the case? Because you not only have to understand the network and the humans that are creating the network of movement and of contact, but also the bacteria or virus you are targeting and you want to stop. Because a respiratory virus you can transmit in the supermarket quite easily. You can just cough, sneeze, etc. And the cashier, for example, gets infected too. However, for Staphylococcus aureus, a bacteria that is in the throat and nose area, is usually transmitted by more direct contact, like shaking hands or kissing and such things. And as you can see here, apparently the Dutch and the Germans still do not share a lot of love because there's not a lot of kissing, there's not a lot of transmission going on because you're not shaking and kissing, you're not shaking the hand and kissing the hand of the cashier or the petrol station guy, at least not often enough to see a genetically relatedness, which means you need to understand the pathogen and you need to understand the borders of human networks because it all comes down to contact. But there are other network boundaries which are not so easy to understand at first glance. because they are also, and I want to show you one example which I think shows it quite well before diving into the current research we are doing on that topic. This is a group, a group of mathematicians who did that. They used, there's a website in the US where you can put in the number of your dollar bill to see where this dollar bill have been before, and they used it for modeling to define network borders, which means if you spend $1 here in Texas, with 95% probability, this dollar bill will remain in this area outside of the blue line here. And what you can see here is, I cannot really ask you the question now, I will explain it, is that you can see borders that are quite, well, natural. This one here, for example, is the Mississippi. It's a large river, so people are not crossing it very often, maybe because of bridges, traffic jams, etc. I think you can not see it so much in Bonn, but you can see it in larger rivers where you have cities not on both sides of the rivers quite often, that people are, and now with the Nordbrücke being closed, maybe you see the same pattern in Bonn as well, that people are staying now in Boyle as much as they can. And you have, for example, the Appalachians, which is a mountain ridge here. People are also not crossing. And then you have borders like the state borders. You can see here on the left side, they are like rectangle borders, which is just the state border. And even though it's the United States, there still are some differences. Police officers have a different uniform, etc. pp. So people are just staying in their province, in their state. You don't see that much in the Federal Republic of Germany, because the borders are even less so than the US, but it's also because it's a much smaller scale. The states in the US are much larger than the, let's say, Bundesländer provinces in Germany. However, you can also see very weird borders, like this one here on the left, or this one here up there, which at first glance is not so easy to understand, but these are psychological borders, for example. But they have an impact for infection control purpose, because if you have an outbreak here in Seattle on the left side up, you need to inform the state, of course, but you also need to inform this part of the neighboring state, because this is basically a population that is shared. They are staying in the same area. This border between these two states does not exist. And what is the case? Why is that? You can guess for yourself now a little bit what kind of psychological border this might be, because it's not a geographical one. It is just because this country is large, it is a time zone issue. This, for example, here, it's indeed the difference in time zone, and it's psychologically, because you don't want to go starting at 3 o'clock, driving 5 minutes, and you arrive 1 hour later. It's just weird. It confuses you. It messes up your agenda. You are missing appointments and all these things. So people are not crossing that border. And you need to be aware of that kind of thing to understand how transmissions are working. So what we do in the hygiene or infection control part in Germany now is that we try to translate that to the hospital and public health setting. So what we are doing with several projects, not only we in Bonn, of course, these are consortia projects with different university networks, basically, is that we are doing network analysis and visualization of transmission chains with the purpose of predicting them as well, and with the purpose of automating these analyses. And so that we get an alert that if something is happening in the hospital, that we don't have to go like we did 20 years ago, for example, that you actually had to go through paperwork to see whether there is a patient in the surgical ward A and the surgical ward B that has the same bacteria or the same infection, and you check whether there is an epidemiological link, meaning you look at the location and the time if there's overlap. Nowadays, we are trying to do that like this. We are trying to combine this in automated networks that show us on the left bottom here, if a patient A has contact with patient B, etc., what kind of wards they were on and which kind of diagnostics they get. So it's basically the idea what we did with paperwork to get it automated. And I think due to the disruptive innovation of artificial intelligence and learning algorithms and all this becomes more and more the reality. And it becomes much easier to assess these data and this huge amount of data. And this is a challenge, of course, the data we create, but it's also a huge opportunity I want to present to you. Because we can use this data, the epidemiological data, but also the sequencing data, to actually assess chains of infection and routes of transmission. I want to show you a project which we did with not with the university, we are the university, sorry for that, with the city of Bonn, with the Oberbergischen Kreis, and INFAS, which is an institute doing social and spatial research. We did for COVID-19 an analysis of all the waves, the first, second, third, fourth, that hit Bonn or the world basically, and we tried to analyze if there is a pattern, because when we were in the middle of the pandemic, I'm sure you remember, we always had the idea that this is very chaotic. Anyone can get corona, we don't know when it happens, we don't know why it happens, but this in retrospect was not the case, was not true. When we analyzed this, you could see for the city of Bonn, for example, the redder, the higher the incidence rate were, so the more infections occurred there. And we saw a pattern. So the areas were hit in the same way. The second wave had the same pattern as the first wave, fourth wave. And we could use this as a predictive score. So we could say, okay, the next wave will probably hit here and there, and it was right. So we needed to understand why this was right. Well, what we did, we did additional analysis and data. We received the place of residence, type of housing, apartment buildings, etc., housing situation, movement data, and combined it with the COVID-19 cases. We did that, of course, anonymized together with the city of Bonn. And we wanted to analyze whether a person's job, for example, the commute he, she does, all these ways that people are doing have an impact, because, you know, if you only look at the resident area where people are living, and then you say, okay, here's an infection or not, then you don't see the whole picture, because people are going to work. I mean, they are registered in Boyle, for example, and they have their infection registered in Boyle, but the infection might have occurred while they were working at the University Hospital in Bonn on the other side of the river. So there's a bias. We need to overcome this bias, and this is only possible if we have the movement data. What we saw while analyzing that was that infections mostly occurred within the same and particular social class and age group. And super spreader events that always were in the media, they were really, really rare. This is not the driver of infection. This is the one that is blown up in the media. You have a concert or whatever, and the DJ was positive and 200 other people as well. However, the main spread of infection was not because of super spreader events, was just the regular transmission. And we also saw that different social classes were affected to varying degrees. And what we assumed and also could show is that the infections occur primarily in social and private settings rather than in the workplace. Because what you can see is if you have within one social class and age group the most infections occurring, that usually means it's private. Because in the main areas of work, consider yourself, you are not in the same age group. For example, if you're doing research, you have young PhD students, old professors, etc., etc. It's not the same age group. And also many times different social groups, because look at the hospital, you have everyone. You have the technicians, you have the doctors, but they have the cleaning staff. You have very different social classes that are not per se meeting in their private life, because unfortunately in private life we are living in our own bubbles. Our children, if we are at the university, usually go to the gymnasium and all that stuff, so they are living in a bubble most of the time. Now it's World Championship, so in soccer it's not the time. If you're sending your children to the soccer club, then there is a mix of social groups, which is very good. But usually we are separate, because if we're having a barbecue, we're inviting our friends, they are usually from the same social class. So we thought, okay, this is quite known. This means one good thing. We controlled coronavirus in the work environment setting quite well. That's a good thing. It worked. However, the social and private setting is not so easily controlled, because people are not doing what you recommend, and also the politicians recommended back then many things that were not, from infection control purpose, correct, and sometimes way over the top. So the other thing that popped up and we found interesting is that we saw that different social classes were affected to varying degrees. In the first wave, it was the high social class with high income. And after that, the low social classes. All the other waves hit the lower social classes. And why is that? Well, the first wave was the introduction of Corona. You might remember Ischgl, the ski event. But who goes skiing in Ischgl? It's quite expensive. You know, who gets infected there? It's the higher class that is able to pay for that. So we tried to shine more light on these social aspects. And what we did was we got together with also other groups, not only from the medical faculty. And we looked at the deprivation index, which is a score that takes into account the money that you earn, the degree of education that you have, all these things. And this is a map of North Rhine-Westphalia, so where we are living at the moment, or located at, sorry. And what you can see here, there are differences. So in these little areas, you have one that are more green, which means it's a good standard, high educated people, higher income, etc. But there are also socially problematic areas. Okay, this is what was the case before the pandemic. And this is now, if you lay over from one of these, this is Oberbergischer Kreis, the score, the deprivation index here on the left side, and the incidences, so the coronavirus rates. And at first glance, you see, okay, this pattern is surprisingly tight, surprisingly alike. And this is not good, because if you see a pattern like this, then you know, okay, even if you're just looking at this from an over-the-top view and not really going into detailed research, you see that there is a social pattern that has an influence on transmission dynamics, which means that we are doing things not in a way that they are supposed to be done, because maybe vaccination was not the same uptake in the lower social groups than in the higher groups. Maybe we didn't translate everything. Maybe we took not into account language barriers or other things. Anyway, we didn't reach all the people in the same way we wanted to. Some things are not easily controlled. For example, the classical household issue. You can live with 10 people in one household, then 10 get infected, and you can live with only 2. These are some things that you cannot change as an infection control specialist, but the things like vaccination and treatment, diagnostic, that you can change. But there's also socio-demographic pattern. What you can also try to do, which we did, is surveillance in wastewater, because all this screening cost a lot of money and didn't really have an effect in controlling the infection. So the idea came up, why not look at the wastewater? And we did that as well with several projects. And I just want to show you real quick that yes, it's indeed working. That's the only thing I want to say. If you look at the pandemic, you can see that the incidence is indeed follows the same pattern as what you are measuring in the Bonn wastewater. And the same with an endemic setting. You can see the spikes. They are quite well overlapping. Then we asked, or Jan Hasenauer, because was very bad in mathematics at school, and I still am, so I still don't understand all these things that are done, but we were interested in modeling this. Can this be also used for predictive measures? What happens when it rains, for example, more water comes in? And we combined the skills and expertise of Jan's group. And thank you, Jan, if any of your group or Nina is listening, thank you for that. And we combined it with our laboratory expertise for the city of Bonn, and we also did it in a theoretical idea with other cities at the Rhine or not the Rhine in the wider area. And what we did is that I don't understand what they did. So they did all these little formulas. I cannot explain anything of it. It's all in the paper. But what they basically did is the standard model that you're using is susceptible. So you are susceptible for infection, then you are exposed, then you become infectious, then you recover. And then there are ways out. You can die, for example, you can get reinfected, etc. But this is the basic model. we did that with the fixed transmission rates that we had quite good data on for the Omicron virus, for example. And then they did this integrative universal differential equation, which I don't understand. However, what they were able to do in this model to integrate non-stationary drivers like policy, behavior, and seasonality. And we used all our epidemiological and real laboratory data, our sequencing, etc., to make the model better and to see if it works. And basically, it really did work. We could predict, so the model was able to predict the things that we actually measured. And this is quite good, actually, because wastewater surveillance can not only be done for SARS-CoV, it can be done for antimicrobial resistance, it can be done for other viruses, and it's very cheap compared to getting screenings from humans. And it gives you the possibility that it is anonymized. You don't see actually the individual person, but you can see the area where an infection is happening and occurring. You can also do it for drugs, by the way, if you're interested in drugs. So to dive a little bit deeper into what we are doing with the sequencing of pathogens and what kind of dynamics we are trying to assess there, is that we wanted to go into this One Health approach that I showed you in the beginning. So are we all connected? Is the environment connected to humans and the humans to animals? If we eat the animals, if they have been treated with antibiotics, do we eat the antibiotics? Do we eat the multi-drug resistant organisms? Are we colonized, etc.? What's happening with the multi-drug resistant organisms in the wastewater, in the lakes, etc.? So is this really true that we have one bacteria, one multi-drug resistant organism that goes from humans to the environment, to the wastewater, or to lakes, we swim in it, and then back to the animals, to humans, etc., etc. So what we did, we started with multi-drug resistant organism and wastewater from the municipalities, from cities, but also from poultry and swine slaughterhouses to get into the, let's say, animal food production sector. What we found is that indeed in these wastewaters, we find a lot of multi-drug resistance and a lot of multi-drug resistant organisms. This table is very long, and we indeed found a lot more in the hospital wastewater and in the slaughterhouse wastewater compared to regular municipal wastewater. However, if you go deeper into the pathogens you see that the virulence factors are of little relevance compared to human strains, and they are genetically not related, which means that you have maybe the same Klebsiella, but the Klebsiella from the hospital sector, is very different genetically to the Klebsiella from the animal sector. However, these bacteria, as I mentioned before, even if they are not genetically related, they can still exchange genetic material with each other. So it still can happen in the water or in the gut if you have eaten or drank the bacteria. They still can be exchanged, meaning that if you have a bacteria that is colonizing poultry, chicken, still could be, let's say, transferring resistance genes to your bacteria in your own gut. But if you look at them, this is another study we did with methicillin-resistant Staphylococcus aureus, so MRSA, in pigs and in humans. And you see the same pattern. The virulence factors, the classical virulence factors, I just wanted to depict here a couple, they are present in all the hospital strains because these strains are adapted to humans. They are not present in the pig strains. They are really different. Genetically, they are not the same. They have the same name. They are all called MRSA, but they're genetically very different. Means that they have a different evolution. Bacteria are able to have the next generation ready in 20 minutes, which means that 50 years of evolution can have a huge impact in the bacterial world. And 50 years of evolution in the hospital and human sector makes a bacteria very adapted to the human part and not adapted to the immune system of the pig so much. And if you go further than that, you see that the hospital-acquired strains and the livestock-associated lineages are not genetically related very much. And the livestock-associated ones primarily colonize and infect people only that are in very close contact, like the pig farmers. But they are going into the pig they are going into the pig farm, and they are in the dust which is full of bacteria. So they are in such a high dosage that they are indeed prone to get infected or colonized with that. But interestingly, if you send them to a holiday for 2 weeks, not in contact with pigs, they lose this livestock-associated MRSA quite quickly, which is not the case if you're colonized with a human-associated or hospital-associated MRSA lineage. They stick with you because they are adapted to your immune system. And also, if you look at this on an immunological level, you see that granulocytes from the humans are much quicker and better in killing pig strains than human strains, because they don't have any mechanisms against human immune system. They probably have something against pig immune system. And I want to show you that because it's, if a Staph aureus and a Staph aureus with having the same name and are from pigs or humans, they are, of course, 95, 98% genetically identical. But this 1.2% difference in genetics is a difference like this. We are only 1.2% genetically different from chimpanzees, which is not a lot. It's 1.2%, but it makes a huge difference. And we forget that. We tend to forget that even though bacteria can be closely related, 1% difference can be the genes that makes you an ape or that makes you a human, which in not all the cases, but hopefully in many cases, it's a huge difference in behavior. So we went further. This is from this year's research. And what we did is we looked at hospital wastewater because the patients are receiving antibiotics. So in the hospital wastewater, we find a lot of antibiotic residue, and we found more antibiotic-resistant bacteria, which also are, in the first part at least, adapted to humans because they're also in the wastewater from the patients. What we found was an Aeromonas subpopulation in different wastewaters. We compared different wastewaters from different university hospitals. And what we found was that Aeromonas is the neglected brother of or sister of Pseudomonas. Pseudomonas creates a lot of problems in the hospital setting or in the public health setting, creates pneumonia, infections, for example, etc. Burn victims have a lot of pneumonia, wound infections, but Aeromonas rarely causes an infection. It's adapted to the water setting, not so much to the human setting. There are infections, but not comparable to the vast amount of infections Pseudomonas is doing. However, we found this Aeromonas, which had compared to isolates from the clinical setting. This RAG here means antibiotic-resistant genes. The average of antibiotic-resistant genes in a bacterial isolate we find from the hospital is 2.6, and this wastewater Aeromonas had 14, which is really a lot. And we wondered, why does it keep this? Why does it keep these genes? Because these genes, if you're going to the next generation, if you duplicate, this costs energy. You have to duplicate more DNA. So the bacteria usually doesn't want to keep this for a long time. However, it does keep it. So one explanation could be and is that if you are in the hospital wastewater, you always have low dosages of antibiotic residue in the wastewater. So you just keep it to survive. However, there's another reason which we were not aware of. Because when we don't have to read everything, just the takeaway message. When we dove deeper into the genome of this Aeromonas, we found that this actually is a petrol station. It's a platform. It is so highly enriched with mobile elements compared to clinical isolates or other isolates in the wastewater. It basically means that every bacteria that swims and comes across these Aeromonas gets in contact with it and exchange DNA. So this Aeromonas takes everything in and also distributes chaotically to others that are swimming by, which is quite interesting. It's really like the petrol station at a highway petrol station. Everyone stops there and gets something and moves on. Which means that if you have strains like this Aeromonas, and this is just really very recent, so we are trying to understand it better. But what we see is that in this case, the clinical wastewater can indeed serve as an evolutionary niche for really highly plastic resistant constructs. So there is a lot of exchange. And this is something that is much more difficult to assess, because now we have to look at genetic material, at genetic genes that are exchanged. We cannot go with the relatedness anymore. We have done this for 100 years with colors, with the name, and then with genetics to see if bacteria are genetically related to each other. Then we said it's a transmission. Then we said, okay, they have been transmitted from one person to another. Now we see that this is not true. Also, if bacteria are not genetically related, the problem, maybe the greater problem, is the exchange of bacteria, of DNA, of genetic material, of plasmids. And plasmids are much more difficult to track because the techniques are more expensive, more labor intensive to actually track plasmids. But this is something we don't know much about. We have to go deeper into this plasmid and gene-related transmission dynamics. And this is just closing it up, just a couple of more slides, because I just wanted to show you how artificial intelligence might also influence hygiene and infection control, because I think it will affect everything. And I want to end my talk just with one thing we did not do, I found interesting, and also a little bit Big Brother is watching. Another group did. What they did is they use smart watches and smart drinks and all these fitness apps that are measuring your heart rate, your temperature, and your rhythm of breathing. What they found is that if you have a large data set, you can actually predict infections, because there are subclinical changes if you are infected before you even feel it, like increase in resting heart rates, increase in breathing frequency, slow things. That can also be if you're doing sports, obviously. But if you have mass data, many people, then this actually becomes predictive with AI, can learn from that, can predict, okay, maybe an infection in this group is taking place. And if you combine it with geographical information data and references with Google searches for clinical symptoms like coughing, sneezing, etc., you can actually make predictions that in a certain area, an infection is likely to be occurring in the next days, and also what kind of infection it might be, respiratory or diarrhea, etc. pp. Obviously, this has major issues with data security, but I just want to show you that with the development of algorithms, of artificial intelligence, surveillance overall is maybe something that is now done by experts, but maybe in the future, this will be more based on the internet data that people are using in searches, and also for data that people are giving away for free, like these smart watches and rings and etc. fitness apps. So this is the end of my talk. I thank you for inviting me here and for listening to me. And obviously, I'm happy to take questions. Thank you.